Right, we're diving deep today, really deep into sepsis and septic shock. And, we're going way beyond the basics here.
Yeah.
Because you sent over a ton of research and guidelines.
It's a really important topic.
Absolutely.
Yeah.
So I really want to make sure that we equip you with the latest insights.
Some cutting edge stuff in here.
Yeah, for sure. So let's get started with, I guess the fundamentals. Like, what are sepsis and septic shock? Your material defines it as a syndrome
Right.
triggered by infection
Yeah.
that leads to this like whole body inflammatory response.
It's not just inflammation, though, right? It's like this crazy cascade. It's really fascinating, actually, how this all comes together.
Yeah.
One of the things that your guidelines really highlighted was this connection between inflammation and the coagulation system.
Ah, okay.
And how those two things, play off of each other. And that's what makes sepsis so dangerous.
Oh, I see.
When it's sort of left unchecked, it can lead to organ dysfunction and then multiple organ failure and ultimately death.
Wow, that's a really good explanation. And, speaking of intense, the mortality rates are crazy high.
Yeah.
It's kind of scary.
Yeah, very serious.
10 to 20% for sepsis, then 20 to 50% for severe sepsis, and then it jumps up to 40 to 80% for septic shock.
That's right. So this is not something to be taken lightly.
Yeah, those numbers are really serious.
Yeah.
Okay, so let's talk about early detection then. How early can we catch this?
Yeah, absolutely.
It seems like there's some debate about the best screening tools.
Yeah.
Particularly this QSOS score.
Yeah.
And it's really interesting that the 2021 Surviving Sepsis Campaign guidelines advise against using the QSOFA alone.
Well, the reason for that is that, if you're just using a single scoring system like QSOFA, it can be misleading. It's like trying to figure out what's wrong with a car engine by just checking the oil level, It gives you some information, but it doesn't give you the whole picture. There's just so many variables at play with sepsis. You really need a more holistic view.
Okay, that makes a lot of sense. Now, you also sent over some research on the 1-hour sepsis bundle.
Yes.
This has kind of been like the gold standard for rapid response.
It has.
But a 2024 study by Frines and colleagues suggests it might not be the magic bullet we thought it was.
Right.
They found that it wasn't superior to standard care in preventing deaths, which is kind of a surprising finding.
Yeah, I think the study is a good reminder that while speed is critical in sepsis, we also need to be smart about our interventions.
Yeah.
Simply rushing through the standardized bundle may not be the ultimate solution.
Right.
We have to consider the individual patient needs.
Makes sense.
Okay,
so moving on to diagnostics then.
Okay.
The guidelines that you provided list several investigations that are crucial. First up, hemodynamic assessment. Why is it so important to go beyond that basic clinical exam?
Well, the comprehensive hemodynamic assessment can really reveal subtle changes that may not be immediately apparent just on that initial exam. It helps us accurately determine what type of shock a patient might be experiencing.
Okay.
Which is absolutely critical to tailoring the treatment.
And then, of course, we can't forget about the blood lactate levels,
Right.
which your source is tied directly back to the pathophysiology of sepsis.
So lactate, right, it's a byproduct of this process called anaerobic metabolism.
Okay.
And that kicks in when your body's tissues aren't getting enough oxygen. And so when we see those elevated lactate levels, that's like a big red flag for us.
Yeah.
Indicates potential organ dysfunction.
I see.
So it's a really valuable marker for gauging the severity of the sepsis.
Okay. And then there's microbiological testing, specifically obtaining cultures before starting antibiotics.
Yes, that's very important.
Why is that timing so crucial? Why, before we give the antibiotics?
Because if we start antibiotics without knowing who the culprit is, it makes it much harder to pinpoint the right treatment later on. So by obtaining cultures first, before we initiate these broad-spectrum antibiotics, it allows us to really tailor the therapy to the specific pathogen that's causing the infection.
Okay.
And that minimizes the risk of resistance.
Right.
And ensures that we're using the most effective treatment possible.
So smart.
Yeah.
Okay, now let's talk about fever in the ICU, which comes with its own set of challenges, of course.
Oh, yeah, absolutely.
The 2023 IDACCM guidelines you shared offer some really interesting recommendations. They emphasize using central temperature monitoring for accuracy.
Right.
But what if those methods aren't readily available?
Well, the guidelines acknowledge that they
Okay.
suggest considering oral or rectal temperatures
Yeah.
over things that might be less reliable, like axillary or
Yes,
tympanic.
I see.
So it's all about adapting best practices to the resources that you have available.
Makes sense. They also recommend routine chest x-rays when fever develops in the ICU. Why is that?
Well, chest x-rays are really helpful to rule out pneumonia
Oh.
or other pulmonary complications that can often accompany sepsis, especially in these patients who are already vulnerable.
Okay. And then what I found really fascinating was the recommendation for simultaneous blood cultures
Oh, yeah.
from both central lines and peripheral draws. What's the reasoning for that double draw?
So it's all about calculating something called time to positivity,
Oh, okay.
which is the amount of time it takes for bacteria to grow in a blood culture. By comparing the time to positivity from the different sites, it gives us valuable clues about the source of the infection.
Wow, that's a smart.
So if that central line culture turns positive much faster than the peripheral draw, it suggests that the line itself might be the culprit.
Got it. That's a really clever technique.
Yeah.
Okay, so now on to another hot topic, procalcitonin.
Okay.
The guidelines recommend considering it when the probability of bacterial infection is low to intermediate,
Right.
but not when it's high. Why this nuanced approach?
So procalcitonin is a marker of inflammation, and its levels can rise in response to both bacterial and non-bacterial causes.
Okay.
So if we're already pretty sure that there's a bacterial infection based on the clinical presentation, then adding a procalcitonin on top of that doesn't really add much value.
Oh, I see.
But in cases where it's a little less clear-cut, the clinical picture is murkier, the procalcitonin can really help us kind of tilt the scales one way or the other.
Okay.
So towards or away from a bacterial cause, and that helps us guide our treatment.
Okay, that's interesting. So we've got a pretty good handle on diagnostics now.
Okay.
I think it's time to dive into the deep end of treatment options.
Right.
Fluids, vasopressors, inotropes, corticosteroids, antimicrobials. The list goes on and on.
Yeah, you've got a lot of material here.
I know. So much. So we're going to break this down into different parts. Let's start with fluid resuscitation.
Okay.
The 2021 SSC guidelines are very, very clear. Initiate treatment and resuscitation immediately.
Right away.
This is like a very urgent situation.
Oh.
But then we have this 2023 Clovers trial that kind of throws a wrench in things.
Yeah.
They found that a restrictive fluid strategy wasn't superior to a liberal one.
Interesting.
And that's kind of a surprise because we've always been taught to be pretty aggressive.
You would think more fluids is better, right? But
Yeah.
it challenges that assumption.
Exactly. Okay, so we've talked about getting fluids in fast.
Okay.
But what kind of fluids are best? Turns out, it's a debate that's been going on for years.
A long-standing question.
Yeah, this whole crystalloids versus colloids.
It's a classic dilemma.
Your sources mentioned several recent guidelines and some key trials that kind of shed light on this. The 2024 ESIM and the 2022 SFR-SFMU guidelines both advocate for balanced crystalloids
Over normal saline.
over normal saline. Okay. What about albumin? It seems like it's been a contender in the colloid category, but the evidence is a little mixed.
It is. We have the long-standing Albios trial from 2014, and then more recently, the ABC sepsis trial from 2024. And both of those failed to really show that albumin was superior to crystalloids in terms of mortality.
So while albumin is an option, the latest research suggests balanced crystalloids are generally preferred for fluid resuscitation in sepsis.
It seems to be the way things are trending.
Okay, now let's talk about those medications that are designed to raise blood pressure, vasopressors. The 2021 SSC guidelines recommend norepinephrine as that first-line choice.
Yep. Norepinephrine is a powerful vasopressor.
Uh-huh.
It acts directly on the blood vessels
Okay.
to increase that blood pressure.
You also sent over some information about vasopressin, which has also been explored as a potential option.
It has, but the 2008 VAY-SST trial
Okay.
showed that it wasn't superior to norepinephrine in terms of mortality.
So not the primary choice, but maybe an add-on in certain situations.
Right, exactly.
Okay, so norepinephrine is our go-to. Now, how about inotropes?
Okay.
Those medications that help the heart pump better.
So the 2021 SSC guidelines suggest considering dobutamine
Okay.
as an add-on to norepinephrine, or even using epinephrine alone if you have a patient with persistent hypoperfusion,
Okay.
despite adequate fluid resuscitation and blood pressure support.
What about levosimendan?
Oh, yeah.
It seems like it's been studied as a potential inotropic agent.
It has.
But it seems like the evidence isn't quite there yet.
That's right. The 2016 Lippart's trial didn't really show any benefit
Okay.
in terms of improving organ function.
So we're sticking with the butamine or epinephrine for now.
It seems to be the best evidence we have at the moment.
All right, let's move on to a topic that's always been a bit controversial, I think, in sepsis management.
Yeah.
Corticosteroids.
Oh, yeah.
Seems like recommendations have evolved over time.
They have.
And there's still some debate.
There is. The 2024 SCCM guidelines suggest considering corticosteroids in adult patients with septic shock.
Oh, okay.
But they advise against high-dose, short-term regimens.
So both guidelines are saying that corticosteroids might have a role,
Yeah.
but we have to be careful with those high doses.
Right. And individualized decision-making is really important here.
Okay, what about the BMJ 2018 guidelines? They seem to take a broader approach.
They do. They suggested considering corticosteroids for both adults and children with sepsis. So,
With or without shock.
yeah, shock or no shock.
So it really shows how the thinking around corticosteroids and sepsis is constantly evolving.
It does. It really does.
It sounds like a complex landscape with conflicting evidence.
It is.
It seems like individualized treatment decisions are really key here.
Absolutely.
Carefully weighing those benefits and risks for each patient.
Yeah, exactly.
Okay, now let's switch gears to antimicrobial therapy, which is, of course, a cornerstone of sepsis treatment.
Right.
The 2021 SSC guidelines are very emphatic about starting antibiotics, ASAP.
Yep.
Ideally within 1 hour.
Within 1 hour, that's right.
Of recognizing sepsis or septic shock. Why is that speed so crucial?
Well, because every hour counts when you're fighting a life-threatening infection like this. Delaying antibiotics can significantly increase the risk of complications and even death.
And when it comes to choosing the right antibiotics, the guidelines highlight the importance of covering for MRSA.
Especially in patients who are high risk.
Okay, MRSA is a type of bacteria
That's right.
that's resistant to many common antibiotics.
It can be really difficult to treat.
But here's where things get even more interesting. This 2023 MERCY-Y trial challenged some long-held assumptions about how we give antibiotics.
Interesting.
They looked at continuous versus intermittent administration, and they found that continuous wasn't actually superior.
Yeah, I mean, this is a great example of how we should always be questioning established practices and looking for ways to improve things.
Exactly.
You know, continuous antibiotic administration was considered the standard for severe infections.
Right.
But MERCY-Y is saying that intermittent dosing may be just as effective.
Interesting.
And potentially even safer.
Wow. Okay, so there's definitely a shift happening in how we think about antibiotic administration.
It seems so.
Now let's talk about antifungals, which are also part of that antimicrobial arsenal.
Right. So the 2021 SSC guidelines recommend considering empiric antifungal therapy
Okay.
in patients who are at high risk for a fungal infection.
Okay.
Particularly, this includes people who are immunocompromised,
Okay.
patients who have already received a lot of broad-spectrum antibiotics,
Okay.
or those with invasive catheters or devices.
Got it. But they also caution to avoid initiating antifungals in those who are low risk.
Right. You want to be careful about unnecessary antifungal use.
Okay.
Because that can lead to drug resistance and potential side effects.
Right. It's all about striking that right balance.
Absolutely.
And once antibiotic therapy is underway, the guidelines really stress the importance of that daily reassessment for de-escalation.
Yeah, you want to make sure you're using the right antibiotics for the right amount of time.
Okay, this means adjusting antibiotics based on culture results,
Right.
clinical response, and then that risk of resistance.
That's a really important part of antibiotic stewardship.
So it's all about finding that sweet spot, I guess, between effectively treating the infection and minimizing that unnecessary antibiotic exposure.
Exactly.
Okay, now let's touch on a few other key interventions that are mentioned in your sources. Anticoagulants, for example, are often used to prevent blood clots
Right.
in these critically ill patients. What do the guidelines recommend for those?
Well, the 2021 SSC guidelines recommend against using antithrombin for sepsis and septic shock.
Okay.
And there isn't enough evidence to really assess the benefits and risks of other agents like thrombomodulin or heparin. They do recommend low molecular weight heparin or LMWH over unfractionated heparin for preventing blood clots.
Okay, so LMWH seems to be the preferred choice for now.
Based on the current evidence, yes.
Okay. What about IVIG or intravenous immunoglobulin?
Yeah.
It seems like it was once considered a potential therapy.
It was.
But the guidelines now advise against its use.
They do, because studies haven't shown that it improves outcomes.
Okay.
And it does come with some potential risks.
Now, managing fever is another important consideration in sepsis care.
It is.
The 2023 IDS-CCM guidelines